welcome to How I Ally. This is Lucinda Koza, and I'm here with a fabulous guest. If you don't mind, I'd love for you to introduce yourself and give a bit of backstory or bio.
Absolutely. So I'm Dr. Isabel Morgan, and I'm Senior Advisor of Maternal Health at the Black Women's Health Imperative, BWHI. It's an organization that was founded in 1983 by Billy Avery, really to address health issues impacting Black women and girls across the country. And so we engage in research and programming and education and engage in legislative advocacy to advance Black women's and girls' health. A little bit about me: I'm trained as an epidemiologist and as an anthropologist. And so for many years have studied racial inequities in Black maternal and reproductive health, ranging from postpartum care to maternal mortality, and more recently focus on infertility.
First of all, that's incredible. I didn't know that you trained in anthropology as well.
The epidemiology skills really primarily focus on quantitative data analysis, data collection, and really where anthropology comes into play is, of course, understanding how people are socialized and introducing me and allowing me to leverage qualitative data skills to support the research I'm invested in. So, understanding, talking to people about their experiences, navigating maternal health care, maternity care systems, so that we can develop solutions to improve them.
Wow, that makes complete sense. So, y you said just recently you've started focusing on infertility.
Yes.
So what have you found actually, let me back up. The First of all, the maternal mortality rates in our country, period, are outrageous, correct?
Absolutely. When we look at data from CDC and from the National Center of Health Statistics, and we compare that to data in other countries, we do see that within the US, among all industrialized states or high countries, excuse me, high resource income countries, the US has the worst maternal mortality rates compared to those other countries. And so it's very alarming on where our statistics are and the types of care that women and birthing people receive, because we spend the most money on healthcare, but it's not translating into the results that we need, which is for people to be able to enjoy their pregnancy and birth experiences, survive their pregnancy and birth experiences, and to be able to leave hospitals or birth centers with their babies.
Oh, I feel that so hard. Is that is that because of a huge discrepancy between patient-centered care and everything else?
I think you raised a great point about patient centered care. When we look at the way our healthcare system is set up compared to these other countries, they're drastically different. So we rely on this health insurance model, right? So for folks to be able to access medical care and healthcare through essentially having health insurance to pay for the services of these providers. Whereas some of the other countries, high income countries, they have universal healthcare coverage. So that's significantly different than the way our system is set up. Specifically, when it comes to, excuse me, maternity care, most women and birthing individuals are serviced by obstetricians and gynecologists within our country, within the US, whereas in some of these other countries, the predominant providers are midwives. And so they're using different models of care. The midwifery model of care is quite different than the allopathic medicine and models of care that we use here within the US with obstetricians and gynecologists. And obstetricians are really trained as surgeons. And so their training really positions them to focus on and address abnormal progression of labor and abnormal pregnancies. Midwives are really trained to support the natural progression of labor. And so we do see a shift recently with the attention that's been attributed to the maternal health crisis really within the US is understanding these distinctions and providing supports for obstetricians and gynecologists to shift their practice and how they care for patients, but also in increasing access to midwives and midwifery care for those patients who they are low risk and can experience labor and experience pregnancy without these medical interventions like cesarean sections, for example.
I really didn't know I had a C-section, cesarean, and I didn't even know that was not an ideal outcome. I was just not educated about that.
And it may have been, I don't know your story, it may have been a blessing for you. There are certainly medical indications of cesarean sections, but what is concerning is the unnecessary or elective cesarean sections that we see within our country.
Which is tell me about that data. I know that it's very high, the rate of C-sections. Is that correct?
Of births in the US, babies are delivered via cesarean section as compared to vaginal birth. And that is quite higher than in these other industrialized and well-resourced countries that I've mentioned. We also see racial inequities in cesarean sections. So you'll see in certain parts of the country, particularly in the South, or in these community safety net hospitals, public hospitals, hospitals that are servicing more patients of color, like Black patients, you'll see higher rates of cesarean sections. There's even data that shows that in the same hospital, seeing more cesarean sections, a higher percentage being performed among Black patients versus white patients. And so that's concerning when we think about the implications of those cesarean sections. If they are unnecessary, not medically indicated, the implications for the outcomes from that birth and that delivery, you know this, the recovery time from cesareans is certainly much longer than from a vaginal delivery. There's increased risk for infections and hemorrhage. And so when a cesarean section is not medically indicated, however, is being performed, there's a cascading effect on women, on birthing people, and on infants.
Absolutely. Absolutely. Even the infant, yes, which is outrageous.
If we look at data that we have on pregnancy related deaths, we know that the majority of those are occurring in the postpartum period. And so previously I'd mentioned maternal mortality. We make a distinction between maternal mortality and pregnancy related deaths, where maternal mortality are deaths that occur up to maternal deaths that occur up to 42 days postpartum. And why this random number? This is so that we can be in alignment with data that's reported from other countries at the global level. So that's how we're able to compare our maternal mortality rates to other countries like Switzerland and Sweden. But pregnancy related deaths are data that are collected by CDC, the Centers for Disease Control and Prevention, and they're collecting data on deaths that are occurring up to 12 months after the end of the pregnancy. And that's really important because that's showing us we're capturing that people are dying after pregnancy in the postpartum period. And in fact, that's where most of those deaths are occurring beyond 42 days, even. And so that's really been significant in helping us to understand where these deaths are occurring and really where resources need to be shifted to be able to support people, not just through pregnancy, but also postpartum.
There do you feel or do you in your opinion, or do you feel in your I'm using weird words here. Do you is it your opinion that w women in the postpartum period do not get much care in our country?
There's been a significant shift, absolutely. But there's been a significant shift in directing resources towards the postpartum period. I think that's for so long, there was such a focus on pregnancy. And I think that this actually has to do with our focus and attention on infants and the babies, right? That really being like the woman being a vessel for this life, right? I think that's
Right.
indicative of our focus on the infant, the baby. And then once they're born, they're here, then a lack of support and attention to what the mom or the birthing person's needs are. And so there has been a shift with understanding. We talk about first, second, and third trimester. Now we're talking about the fourth trimester and that being postpartum. So once the baby's here or for after a pregnancy ends, however it ends, the person who delivered needs support. They need care, they need healing, right? And so there has been a shift in understanding that more care is needed. So prior to 2018, the American College of Obstetrician and Gynecologists, or ACOG, essentially recommended that those providers, that people who that deliver, that they're seen about 6 weeks after they deliver, and that's it. And in 2018, the guidelines were actually shifted and changed so that there's touch points more than 6 weeks and more than just one time postpartum, 3 or 4 times of having touch points for providers to be seeing their patients, for patients to be going back to their providers so that they can get screenings for mental health disorders like depression and anxiety, that they can have their blood pressure checked, right? Has been a shift and a recognition that the postpartum period is significant and that we need to be directing more resources and attention to people after they give birth.
That's great because that's so true. Do you think that would do you think that would result in fewer deaths?
Absolutely. I think that the work that has been done to support people postpartum is making a difference. The data that we've seen on maternal mortality in 2023, we've seen a decrease slightly within for at the larger population level. Unfortunately, though, we did see an increase, a slight increase for Black women. And so that's
Mhm.
something that we need to be paying attention to. We still experience racial inequities. We still need to be making strides and supporting Black mothers and Black folks postpartum throughout the entire pregnancy, but also postpartum. But I do believe that this attention to warning signs, maternity care warning signs, for example, has really helped to empower women and birthing people with an understanding about what is not normal to experience and when they should be contacting their providers. I think it's also equipped doulas and other perinatal workers to support their clients with understanding when is it time for them to be seen, how do they advocate for themselves postpartum. I think I've also seen a shift in how we're showing up for each other in communities. And I hope that you had this, Lucinda, like a meal train, your family and
Oh,
friends essentially pitching in, right, with supporting your family with meals, for example. There's like the clinical programming that's being incorporated that I think is very helpful. There's the community level solutions, but like also in families, like people showing up in communities. I have seen a shift in people understanding that folks need support postpartum and pitching in to support.
yeah, and that's what I'm trying to do for sure, to do my part and to just impress upon people how absolutely vital the 4th trimester is, and that the health of the baby really depends upon the health of the mother.
Absolutely. I think that there has been an understanding too that the dyad, in order for the mother baby dyad to be healthy, the mother has to be healthy. That birthing person has to be healthy. They have to be seen. They have to be valued. They have to be whole. And that's why we at BWHI support legislation like the Black Maternal Health Momnibus Package, specifically the Perinatal Care Workforce Act, that is meant to increase funding for these perinatal health workers that I mentioned, like the doulas. And then we have midwives and lactation consultants, community health workers, being able to support people throughout their pregnancy and certainly postpartum.
Are Black women just straight up not seen as human beings as much as their white counterparts.
Listen, to say it. You can say it. It is something that we still struggle with, right? Like, it is a valid question. It sounds ridiculous, but yes,
Yeah.
in 2025, we still have to contend with that. And I think that there are certainly providers and people who are overtly racist, right? I think that there's
Right.
also we've all been socialized to see move through the world a particular way. And certainly there's a distinction in some how we've been socialized like within our homes. But this is why it's been important for us to develop programming and engage in work that addresses implicit bias. So, implicit biases that people have that they're not fully aware of, and how that impacts how they're providing care, even down to the person who is checking you in at the hospital. How they're treating you as you're being checked in to sit in the waiting room, how they are triage, how a nurse might be triaging you, for example, from the waiting room and or from emergency room. So that is certainly an issue that we deal with. It's why CDC developed in collaboration with several partners the Hear Her campaign. And
Mm,
that was to address the fact that Black women are not listened to. And that is the root of that is not seeing, valuing Black women and Black people, certainly. So that is certainly an issue that we still deal with. And again, related to the advocacy work that we're doing at the Black Women's Health Imperative, specifically around the Black Maternal Health Momnibus package, which was introduced by the Black Maternal Health Caucus. There are bills within that package that support growing and diversifying the workforce, the perinatal workforce. And that's really important because it's important that people are seen, like they see people that look like them, that have similar life experiences, that have a particular cultural upbringing, because I do think that helps. If they're not necessarily being seen, if a person's not necessarily being seen by that provider, but that provider's a part of like a care team, they're able to maybe pick out something in like the case study when their providers are doing their rounds before they're seeing their patients for the day, like asking questions in a different way, asking their colleagues to think about these issues in a different way. I can give a personal story. There's a person in my family who had to report to the hospital for a gunshot wound. My mother took them, and she talks about how she had to contend with the staff misinterpreting that they were looking for like drugs. They just wanted opioids. They're reporting to the hospital for care, but because they're Black, because they're a male, he was male, just having this perception that they're here for drugs, right? So this is something that people that I've dealt with in my own family and that we see. And so that's why it's really important for us to engage in programming and legislative advocacy that is growing and diversifying the healthcare providers, that we're addressing implicit bias, that we're addressing structural racism, but it starts with calling it out. So I appreciate the
yeah,
question, and it is a reality.
absolutely. And I grew up in South Carolina, so I certainly, I mean, my whole childhood, we still had the Confederate flag flying over the state house. But it's not really that different in New Jersey where I live now. It's just hidden better, maybe. Yeah. It makes me think of trauma-informed care. If the staff or if the care team actually take the time to know what has happened to the patient, maybe in their past, if they've gone through some trauma, and that makes a difference in how they treat them. It's that kind of personal attention or just really thinking about how you're providing care to this specific person.
Providers have 15 minutes, sometimes max,
Yeah.
as they're going into these. So we think about a prenatal visit, the OBGYN might have 15 minutes max with their patient. So they're trying to basically counsel them at whatever stage that they are in their pregnancy. Let's say a pregnant patient's in reporting to the hospital or the clinic. That doesn't really leave time for the patient to ask questions. That doesn't leave time for them to do like a social determinants of health screener, which those do exist. That doesn't leave time for them to get to know this person as a human being. What are their dreams and their desires? Right. So there's some of that's happening over the course of the care, but we also know that providers might be shifting like their patient loads. And so who you have during your prenatal visits might not be the person that's helping you deliver on your delivery date. But I do think it's important that as much as possible, providers are being trained, retrained when they're already board certified, but also starting with these medical institutions is training the providers, nurses, medical schools, physicians assistance programs, really training them on racial inequities, training them on implicit bias, training them on how structural and systemic racism shows up within the healthcare system. I can give you another example from data that came out of a study out of the University of Virginia many years ago, and it showed that medical school students, they inaccurately believed and reported that Black people could tolerate more pain. And so that was many years ago, but more recently, there's data out of UNC Chapel Hill that showed that Black patients and I believe Hispanic patients were indicating higher severity pain scores, either I think it was postpartum, and they were, however, they were less likely than the white patients to receive medication, pain medication. That's related to my family story. So even we still see these issues around how providers are listening to or not listening to, or the implicit biases or racism that they have against patients. But in the ways that we can humanize the experience, absolutely that can make a difference. I do want to mention some efforts that are existing, like there's the Earth app, for example, that Kimberly Seals Allers has created. It's phenomenal. She calls it like the Yelp of hospital reviews. And essentially, what it's doing is capturing patient level data on what is their experience with a particular hospital. So then, you as a pregnant person, as a family member, as a doula, you are equipped with information on what people's satisfaction is with particular healthcare institutions within your area, and you can make an informed decision. Hopefully, if you have access to, you can make an informed decision about which hospital that you might want to be seen at. And I think that's really great because hospitals do have their own quality improvement programs. They collect data on satisfaction and quality, like the HCAP survey, but they are analyzing that it's a different data source, and you got to be really motivated to fill those out. And so I think that Kimberly's work with the Earth app is really wonderful to complement the data that's captured in HCAPs.
It's genius. I did not fill out any of those. I still always get request like, about my kids after doctor's appointments and stuff, and I never fill them out because 'cause I'm like
Yeah, it's something to think about. You might not have time, but it's something to think about because hospitals do use those data. And I think they build dashboards. Sometimes they're building dashboards and it's informing their training. It's informing how they're allocating resources within the hospital. But we need more of that. We do need more data. We do need more disaggregation of data. So looking at data by zip code, for example. So do you understand
Mm,
like your patients from a particular zip code might be experiencing lower quality of care? That might have to do with classism and how people are being profiled in the hospitals.
yeah, absolutely. Yeah, no, I feel really bad about not filling out any
No,
stuff.
now in the future, if you're motivated to fill out those surveys when you can. And we
Yes.
certainly at BWHI, we really value data. We really value data. It's incorporated into our programming. It informs the research that we do. For example, the doula training curriculum that we were able to implement at Morgan State University between 2022 and 2023, We trained about 38 Black students at that HBCU, and they were able to go on and support about 140 Black families in the DMV area. We leverage that data in our one pagers, in our packets that we use when we're on the Hill and we're trying to advocate for these legislative changes and to support funding for these critical programs to support maternal health.
Oh, man. So it's very important for everybody to share their experiences, and whether it be super casual, like on the app, or in these surveys for hospitals, or both. Or actually, I want everyone to share their experiences all the time. And too often, we feel like it doesn't really matter what we think, or what we have to say, or what we went through, or what happened to us. And we stay silent, especially women.
I think that women are socialized to not speak up, definitely. We're definitely socialized to not speak up. We're definitely socialized to take care of other people, right? Instead of taking care of ourselves. It's why we see that 98% of children are like taken to their well child visits. But then you have 40% of women and birthing people reporting for their postpartum care visits. Like it's certainly related when people use the data. So when you can report your experiences, whether they're terrible or whether they were amazing, like that is helpful and it's really insightful for the work that even we do, right? Storytelling is a huge component of many of our programs and how we engage in narrative shifting. And that's why I feel empowered and motivated in the work that I do because I can see the narrative shifting. I can see the culture shift. I think fewer people not knowing about what doulas are or not knowing about how to advocate for themselves or not knowing about maternity warning signs. I see the shift in the conversations. I see the shift in the media. And so that's something that really encourages me,
Mm.
including seeing women speak up.
Yes. So that must be really rewarding and encouraging.
Absolutely. It is really encouraging because I know that these are issues that we can fix. The other set of data that comes out of CDC we shows yes that we have dire pregnancy related death rates in our country, but majority of those deaths, 80% are deemed preventable. So this is an issue that we can fix. That's just one of the issues, right? We're talking about the most severe. And I think too, like it's important to even think beyond pregnancy related deaths. There's people who experience severe maternal morbidities or like pregnancy complications that don't result in death, but they cause harm to them, like hemorrhage. There are people who experience depression or anxiety. So I'm grateful and motivated that I see a shift in how we're talking about these issues, that we understand that for Black women, especially, it's not innate. There's not a genetic component, it's not biological. It is literally how the system was created and how a number of structures really condition for us to be disadvantaged within these systems and to experience a lower quality of care and more adverse health outcomes. But certainly knowing that there's people that are dedicated to this, that there's movement, that we see the culture shift, that we did see overall a decline in maternal mortality rates in 2023. We've seen funding being allocated towards programming. Like, for example, the National Institutes of Health had allocated millions of dollars to fund research through the Improve initiative on maternity care and on maternal health disparities. And so that was very encouraging. We've seen a shift since then that's a bit discouraging, certainly discouraging, and that we're trying to hold the line for. But there's been a lot of amazing advocacy work, and I'm really grateful that Black Women's Health Imperative has been really in the fight with so many other organizations and has been a stalwart organization for 43 years. It's really incredible what we've been able to accomplish even before my time with the organization. I'm very proud of our doula training curriculum. I'm very proud of our My Sisters Keepers program that educates young Black women on college campuses about their reproductive health and supports them in how do they advocate for their reproductive health with their state legislator. So those are all things that I'm very proud of and grateful that we've been able to make strides in and contribute to.
That's so fantastic. That's so incredible. That's it's just that's so incredible. I do you said that it's almost designed to take your power away, to take your power away in the moment that you are the at your most powerful, or should be,
It
and
should be
then
a
you
joyful experience. It should be a joyful experience. People should be happy, they should walk away healthy, but for so many people, that's not their experience.
and then you feel like it's like your fault. You failed. And then you start out as a parent already feeling like you're a failure. That's then like you're at a huge disadvantage, or at least I was personally. It was so hard to come from that, to to climb that hill from feeling like I had failed so horribly. And I left the hospital without my babies. I had twins, and it yeah. So I definitely needed the C-section, but it was traumatic, and I I left just confused. What just happened? And that doesn't help anyone. That doesn't help our whole society. We need to empower mothers, and at the very least, we're disempowering mothers, if not killing them.
Absolutely. That is such a blessing that you have twins, but it is very traumatic, right? To leave the hospital with your babies being in the NICU. That is a
Yes.
very traumatic experience. And so you're trying to recover, you're trying to make sure your babies are okay. And something that we recognize and understand from the communities that we support and that we operate in is that so many people don't have paid family leave. And so then that is it's the guilt of not being able to stay home with your children. Like first it's the guilt of them being in the NICU, like in your case, and it's the guilt of not being able to stay home with your children that makes it very difficult. And so paid family leave is also a really important component, right? There's so much that we could be doing to better support mothers and birthing people and families that they can focus on healing, they can focus on their families, their babies, and they can really adjust to what is a monumental shift in their family dynamic.
Absolutely. And that is more that's gonna have that's gonna have way more of an impact on society than, shutting down. Well, that's gonna have a more positive impact on society than, like, outlawing abortion and shutting down Planned Parenthoods, and it's so backwards. It's like the f this fight to bring more people into the world, even if it's in these horrible circumstances. But once they're here, there's no interest in supporting them.
There's a lot more that we can be doing to support families, to be whole, to be sustained, to be comfortable, to live with dignity. That's really what it boils down to is to live with dignity and to recognize that people's basic human rights are being violated. So certainly being able to allocate funding towards paid family leave, that is huge. Being able to
Yeah.
allocate funding to support these perinatal care workers, that is huge. Right now, we're talking about retracting funding from Medicaid, really, and reducing the match, the federal match for Medicaid programs. What is really more helpful for protecting maternal health is expanding access to Medicaid. What is more protective for maternal health is investing in our maternity care systems, instituting these quality improvement initiatives, working with organizations like the Black Women's Health Imperative, with community based organizations that serve in the gap, our safety net programs that are really able to support direct these hospitals and healthcare systems on how to best support their communities. There during with the ACA, the Affordable Care Act, public hospitals receiving funding from federal government had to conduct these community needs assessments. And I think that's such, and they had to act on how they were going to address the findings from the community needs assessment. I think that is really important for hospitals and healthcare systems understanding who are the patients that they're servicing and providing care to, and how can they better support them. There's so much more that we could be doing, and we need to be making sure at this time that we are moving in the right direction, as you pointed out, rather than in the wrong direction that would have very negative adverse implications. It already is having that negative adverse implications on maternal health and people's pregnancy and birth experiences.
Yeah. Yeah. I know we've gone over time, um, but it's incredible to speak with you. You you should be speaking all the time, everywhere, every day.
I appreciate that. I appreciate that.
You you have all the data, you have all the right things to say, and you just you we need to hear it. We need to hear it.
I appreciate that. I appreciate you using your platform to elevate this issue. Like I said, I have seen the narrative shifting, but I don't think this is a time where we have to continue pushing forward. Like we have to continue elevating the message. We have to continue staying empowered and informed. We just had a 100 days town hall, and it was incredible with really elevating where we're at, what this moment needs, where we need to be holding the line, where we need to be shifting resources, and what's working well. But as you're saying, what's been really grounding for me at a time where this just seems like unimaginable is that the way people are mobilizing together, like what I'm sharing with you is because I'm surrounded by brilliant minds and compassionate people. So that's why I'm able to
Yeah.
share this information. And so I really appreciate opportunities like this to elevate the work that we're doing at the Black Women's Health Imperative, and really to be able to showcase the beauty and the need for us to continue to be in partnership. Like people need to tap into, who are their movement partners at this time. And we have a lot of resources on our social media pages for people to stay in touch. We have a newsletter. They want to learn about ways that they can tap in and support and just stay informed about what's happening and how it's impacting maternal health.
Yes. We need to keep the presence. We need to keep the presence present. We need to keep the information flowing and breathing and living in the face of everything ugly. So thank you so much. It's been I feel like I've been in church in a good
Not
way.
that I took it at
In a good
church.
way. In a good way. So thank you so much. Yeah, there's so much work to do, but that's why there are people like you
Thank
that
you so
can
much.
that you have to have the stomach for it to fight in a way.
Yes, tapping into the legacy. I'm not the first, I'm not going to be the last, but there's work to be done and there's a legacy. There's an amazing group of people that have been doing this work before me that inspire me. So I appreciate you for sharing this platform for us to have this important conversation. Thank you.
Thank you.